for that, narrow it down based on location and extravascular. We have three major ones. For intravascular, we have some there, but there are some that actually both extra and intravascular, like G6PD, Plasmodium, babesiosis, and stuff. Sickle cell, from basic science standpoint, is we should know the mutation, right? A substitution mutation or point mutation in the beta globin gene that leads to, abnormal structure of the globin, of hemoglobin, and there's gonna be sickled, right? Hemoglobin, they're gonna polymerize into this insoluble, right? Molecule that will change the shape of red blood cells from the biconvex to the sickled, right? Shape. So when those sickled red blood cells, when they are deoxygenated, when hemoglobin is deoxygenated in sickle cell disease, there is going to be more sickling. And they can include, right, peripheral vessels, right? I need to work on the vaso-occlusive crisis, pain crisis, vaso-occlusive crisis, acute chest syndrome, stroke, things like that. Even they're gonna be leading to splenic infarction over time, which will lead to splenic autosplenectomy at some point in their life. Some of the sickle red blood cells get trapped. They get trapped in the spleen, and spleen macrophages will eat them up, right? So it's primarily extravascular hemolysis, although there's definitely some intravascular going on as well. Yeah, and but which means, so before they undergo autosplenectomy, right, it is extravascular. After the patient undergoes autosplenectomy, when the spleen is no more working or it has undergone fibrosis and atrophy, which will be after, like, by the time they are teenagers, yeah, it's going to be primarily what intravascular hemolysis, right? So sickle cell can be both, for sure, depending on if the spleen is still there or not. There's a micro link here. In sickle cell disease patient, once the spleen is gone, what do we do? What are they at risk for now? Right, they're going to be at risk for encapsulated bugs, right? Infection, strep pneumonia, meningitis, Haemophilus influenza. So we need to vaccinate them, right, against those bugs, right? Yeah, because we need the spleen. There are B cells, certain B cells in the spleen that makes antibodies that allows us to destroy, right, encapsulated bugs. Yeah. So if the spleen is not functional, big problem. So we should do that. Hereditary spherocytosis is due to a cytoskeleton protein mutation, right? Spectrin and Kirin, right? Mutation, which will change the shape of red blood cells. So instead of being the biconvex, they become spherical. And on peripheral blood cell, you're going to see red blood cell without what? The central pallor, right? Red blood cells without the central pallor. And also, you're going to see increased MCHC, mean corpuscular hemoglobin, right? Mean corpuscular hemoglobin concentration. This MCHC is almost equivalent to the work of chromatia, a color of red blood cell. So red blood cells with the appropriate, they really have the central pallor, and that's the normal MHC. The central pallor is absent, which means they are diffusely pink cytoplasm. It's going to be, it corresponds to having it corresponds to having high MCHC, mean corpuscular hemoglobin concentration. So we're going to see that in hereditary spherocytosis. This is autosomal dominant inheritance. It has AD inheritance pattern. So there will be like a family member, one of the parents will have the same problem or disorder. Of course, they're asking you what will be curative in this patient. It's definitely going to be splenectomy, right? Splenectomy is going to be curative in this patient. Removes the spleen, decreases hemolysis, right, of red blood cells, because spherocytes, just like sickled red blood cells, they're going to get trapped in the spleen. They can't squeeze through the splenic sinusoid, right, in the red pore. They're going to get stuck there, and the macrophage will come in and basically eat them up, right? Yeah, so that's going to be important. So, and then those people too, they require what? Vaccination, right? Against encapsulated bugs once the spleen has been IgG autoimmune hemolytic anemia. The test that we use to confirm autoimmune disease is going to be what the Coombs test, direct Coombs, right? Test, right? Direct Coombs test. It's a test that can detect IgG red blood cell complexes in the blood, right? Yeah. So the what does phagocytosis and IgG autoimmune have in common? There, well, besides being both besides both causing Normocytic anemia with reticulocytosis, they both cause spherocytes as well. You're going to see spherocytes on peripheral blood right, in both of them. So IgG also has spherocytes on peripheral blood as well as hereditary spherocytosis. So the difference will be the Coombs test. That's the best way to tell them apart, as well as maybe the patient's age, family history, right? Things like that. But they both have spherocytes and peripheral blood spleen. And the red blood cell in this case, they are probably destroyed were in the spleen because splenic macrophages have what? Receptors for the FC region, right? Of IgG. So if IgG is bound to red blood cells, if IgG is bound to red blood cell, then macrophages can bind to the FC region of IgG and they're going to recognize, right? They're going to think that red blood cells are basically, opsonized, that they're falling, right, and start eating them up, right, and destroying them. So that's why also in patient with like a refractory patient with IgG autoimmune disease refractory to steroids or immunosuppression, we usually give them what we give them. Um, so we can do rather splenectomy, right, in those patients. And this will be an example of what type 2, right? Hypersensitivity reaction, antibody mediated. Okay, so that is that. G6PD deficiency, G6PD enzyme makes NADPH, right, which neutralizes free radicals, oxygen free radicals in red blood cells. So if the enzyme is deficient, there is no free radicals there's accumulation rather of free radicals and red blood cells can start getting destroyed in the spleen as well as in the vessels, in the blood vessels. We're gonna see like bite cells on peripheral blood cells. We're gonna see Heinz bodies on peripheral blood cells as well. In malaria parasite infection, yeah, Plasmodium falciparum varieties. So we have this cyclical fever, chills, body aches, etc. After recent travel, right? Or after recent travel to an endemic region. Yeah, Africa, South America, continent Asia, things like that. So, and we're gonna see like red blood cell inclusion bodies, like ringed red blood cell inclusions, and that suggests plasmodium. Also, this is usually both intra and extravascular. They can have like splenomegaly and all that. Babesiosis is usually transmitted by tick, Ixodes tick, right? Ixodes tick. So it has the same. The endemic region is the same as what Lyme disease, like areas like Massachusetts, New England, and stuff, right? Yeah. So um, this still looks like Plasmodium actually. Looks like it's gonna present like you're gonna think they have malaria parasite, like Plasmodium infection. But this is someone that's never left the US or they've not recently traveled out of the country, but they're presenting like they have plasmodium. Suspect it might be babesiosis, especially if they've recently, right, gone to like Lyme endemic region, Lyme disease endemic region. Yeah. So recently camping in those regions and then now they're presenting like plasmodium, but they've never left the country. It's gonna be babesiosis, not plasmodium. So this also they usually have inclusions, right? Red blood cell inclusions, like the Maltese cross, right? Inclusions. And you're also gonna see splenomegaly and all that. Yeah, in babesiosis as well. So another thing they love to ask is this. So you're giving a patient with babesiosis, right? You're able to recognize it looks like malaria infection, or patient hasn't left the US. You see the geographic region. Okay, this looks like okay, there's tick infested area, and the patient has babesiosis. The question might ask you, what other infection is transmitted by the tick response for the patient's current infection, right? So, of course, Borrelia burgdorferi, Lyme disease, same tick, Ixodes tick, yeah, transmits both of them. I think Ixodes also transmits another parasite, maybe Ehrlichiosis or something, or anaplasma. Yeah, so something to check up just to know all three. I think there are three of them. Yeah, and it's Borrelia, babesiosis, and maybe Ehrlichiosis or anaplasma. So, Ehrlichia and anaplasma infect like granulocytes, macrophages, and all that. Yeah, babesia is red blood cell line with no Lyme disease. So they can ask you about that. Or give you somebody with Lyme disease and ask you what other infection can they develop, right? Babesiosis. Or they have Lyme disease and now they're presenting with, cyclic fever, chills, etc., red blood cell inclusion, which anemia. Yeah, patient has babesiosis, right? Yeah. So just know that connection. PNH, there is a GPI deficiency. It's a membrane anchor glycoprotein or glycophospholipid rather. So GPI, glycerol inositol phosphate, right? Yeah. Anchor protein, anchor phospholipid. It can anchor basically enzymes and proteins, right, onto the cell membrane. So one of the proteins or enzymes or molecules, it anchors to the membrane of stem cells. Myeloid stem cell is what is DAF, a K accelerating factor, or CD59, right? And CD55. Prostaglandin, CD55, 59, the K accelerating factor. The function of DAF is to inhibit or break down MAC, membrane attack complex, right? Which is complement C5b to C9. And MAC, membrane attack complex, formed by complement, terminal component of the complement pathway, which normally destroys cells, pokes a hole in cell membrane, destroys things. The function of DAF is to inhibit that. So in patients with PNH, where there is no anchor protein, no anchor phospholipid, no GPI, GPI is missing, which means everything it anchors on the membrane will be missing. In DAF, those patients, they are stem cells which gives rise to red blood cells, platelets, right, and neutrophils are going to be susceptible to what? To destruction by MAC molecule or MAC, membrane attack complex, and that destruction will be worse at night because complements are better activated in what? In acidic pH. So when we're sleeping, we are hypoventilating, CO2 accumulates in our blood, we develop respiratory acidosis, and there'll be a lot of complement activation during that period, and that will lead to destruction of stem cells, red blood cells, right, platelet neutrophils in those people. So when they wake up in the morning, they're going to say what? There'll be hemoglobin in their urine, right? Hemoglobin urea, hence the name proximal nocturnal hemoglobin urea, PNH, yeah. So the treatment definitely was block complement. So we have monoclonal antibody against C5 complements, can inhibit complements and decrease activation and decrease hemolysis, right? Those patients, PNH. Then we have a group of conditions we call micro and hepatic hemolytic anemias, right? MAHAs. Whenever a patient has hemolytic anemia and you see schistocytes on peripheral blood smear, schistocytes, element cells, fragmented red blood cells, this is some sort of mechanical, right? That alludes to some mechanical destruction, right, of red blood cells, which can take place in small blood vessels, right? Microvascular vessels, microvascular, right? Or microangiopathic hemolytic anemias. So differentials include what? DIC. When you see that, I'm thinking DIC, TTP, HUS, HELP. Those are my differentials for MAHA. Sometimes this mechanical destruction can take place in larger vessels or sometimes in the heart. In aortic, they call those macrovascular, right? Or macroangiopathic hemolytic anemia. That will be due to maybe severe aortic stenosis. aortic stenosis. After catheterization, like aortic catheterization, the catheter itself and co, right, can actually mechanically destroy red blood cells, right, as it's moving through the blood vessels. So I suspect of course, DIC typically triggered by like trauma and sepsis, bacterial sepsis and stuff. DIC leads to widespread consumptive coagulopathy in the body. So all the coagulation factors are going to be activated, platelets will be activated, they're pumping clots, all those clots are going to be destroying red blood cells. So basically, when the key here is to look at the coagulation cascade of the labs we're giving. Patient is they're telling somebody is bleeding from their nostrils, from their mouths, from their ears, from every orifices, from from even the IV side. It's likely some of DIC that would do it, right? In that case, even postpartum women can get it because of amniotic fluid embolism and stuff. So in this case, all the correction factors will be what, low. So my PT, PTT, all of them will be high. Platelet count will be low. D dimer will be increased, things like that. Yeah, I'm dealing with DIC for sure. TTP is an autoimmune disease, typically, where patient is making antibodies against, or the immune system is making antibodies against Adam's TS13. Adam's TS13. Adam TS13 is an enzyme that breaks down von Willebrand factor multimers to degrade von Willebrand factor. So if Adam's TS13 is inhibited by antibodies, von Willebrand factor will accumulate, form multimers which will activate platelets. These people usually have low platelet count, but they don't have abnormal coagulation factors. So PT, PTT, INR, D-dimer, all those things will be normal, but they have low platelet count, and they're going to have other features, right? Fever, renal involvement, neurologic symptoms, etc. HUS looks like TTP, right? Basically, presentation-wise, everything-wise, except now being the kid with recent hemorrhagic, enterohemorrhagic E. coli infection. So a kid suddenly had bloody diarrhea from enterohemorrhagic E. coli and now presenting with same feature as TTP, dealing with HUS. Is due to Shiga-like toxin, right? Damaging the blood vessel, leading to right platelets formation as well as red blood cell destruction. HELP is actually with preeclampsia. So a pregnant woman, pressure is super high. There's protein in the urine. They also have elevated liver enzymes, low platelets, right? Hemolytic anemia. We're dealing with HELP syndrome, severe preeclampsia. Yeah, so those are going to be MAHA. Other minor things like PK deficiency, pyruvate kinase deficiency. So where the pyruvate kinase enzyme in glycolysis pathway is deficient, red blood cells cannot make oxygen and cannot make ATP rather from glucose. So that leads to what? The pump stops working, right? There's no ATP in red blood cells, but as ATPase pump stops working, sodium calcium will accumulate within the cell, and that's will lead to what? The red blood cell swells up and they're gonna rupture, right? It's hemolytic anemia in that case. Then we have IgM autoimmune, right? Those are the cold agglutinins. This is typically shared with what? With mycoplasma pneumonia infection. And so we have IgM that will coat red blood cells and they agglutinate and destroy red blood cells usually in the periphery, in the vessels, primarily. And this is the intravascular right, hemolytic pattern. Maybe I share with recent mycoplasma pneumonia infection. We're dealing with IgM autoimmune. Also, this will be confirmed with like a direct Coombs test, or you see blood agglutinate, right, when exposed to cold temperature. Yeah, that'll be IgM autoimmune. Right? So these are going to be triggers for hemolysis. So something to like read for production issue, right? Iron issue, maybe ACD can do that. Bone marrow space issue, right? Leukemias, cancers, fibrosis, blah, blah. Erythropoietin deficiency, definitely CK deficiency, or sometimes erythropoietin resistance, where erythropoietin is high, but the receptor is not working. Yeah, that may present early with some sort of anemia. And then stem cells, yeah, destruction, aplastic anemia, B19, infection, chemo drugs, yeah, those things can affect the stem cells. So these are monocytic.